This is an 87 years old lady who was referred to us by the surgeon who performed one day before the cataract surgery. It was a morgagnian cataract, but the surgeon had a complication, posterior capsule rupture during IOL implantation, which was followed by the drop IOL in the posterior segment. So the patient was referred to us with quite an advanced corneal epithelium, which you will see we will need to remove it in order to see better. And we are preparing for 3 ports 25 gauge vitrectomy. We noticed the IOL fallen exactly on the retina, on the macula, and we perform now the core vitrectomy and the peripheral vitrectomy without indentation, but we want to cut as much peripheral vitreous as possible without indentation. Our goal is either to remove it completely or to use the same IOL to suture at the sclera. And the decision was related to the status of the anterior capsule, the capsulrorhexis, which looked quite good and complete. So we decided to remove it completely and to use another IOL to implant it on the anterior CCC. First, we tried to remove it with crocodile forceps, but it didn't work. The haptics are quite large. Then we tried to use the cutter with very high vacuum, but again, it didn't work. So eventually we injected a bit of heavy liquid perfluorocarbon in order to protect the macula and to help us in rotating a bit, flipping a bit the IOL, what you see here now, which was very helpful in grasping the IOL further on. We brought it so easily in the anterior part of the posterior cavity, and now with 2 hands technique, via the trocars and then via the paracentesis, we bring the IOL in front of the iris, lying in the anterior chamber on the iris. At this point, we inject again OVD, which is much helpful than it was before, because prior we injected OVD, but it fell all on the posterior segment. Now it is really very helpful, viscout especially, who protects the cornea during our maneuvers to remove the IOL. So we want to cut it into pieces, but not completely, because we don't want to lose those 2 halves again in the posterior segment. So we cut it using a normal scissors, Vanna scissors, only 2/3 or 3/4 of the diameter of the optic of the IOL. Again, OVD protection of the cornea, and now with simple teeth forceps, by rotating maneuvers, we remove the IOL from the anterior chamber and from the eye. In order to be safer implantation of the 3 pieces IOL, we prefer to enlarge the limbal incision at 6 millimeters and to implant the IOL unfolded, because it is more controllable and much safer to implant it unfolded than folded. The forces if you implant the IOL folded, either with forceps or with cartridge, the forces of unfolding can be so strong and you cannot control that well, the positioning of the IOL on the anterior capsule. So this is what we did. We implanted unfolded, we checked that everything is okay, and then we push a bit the optic to obtain the optic capture. And now we came back to the posterior pole to aspirate the PFCL. We sutured the limbal incision with 310 nylon suture. We removed the trocars, and now checking the IOP, we saw that it's a bit soft, so we filled the eye with more BSS via paracentesis, and we left the eye with BSS. And that was the surgery.